Good evening, everyone. Welcome to Walking on Clouds, Foot and Ankle Pain Relief Strategies with Dr. Adam Bitterman. We're going to be getting started here in just a moment, but before we jump in, I'm going to introduce you to a few of our folks on hand. You will see Deborah Goodman, who is a member of the Marfan Foundation team, in the chat, dropping some links and also providing any other information. So she is our behind the scenes magician today, and we'll be happy to help you out with anything you need. My name is Angela Christ. I am the director of the Loeys-Dietz Syndrome Foundation and the director of marketing at the Marfan Foundation. And we are so excited to be almost wrapping up now our final week of the International E3 Summit, Educating, Empowering, and Enriching Our Community. This whole event has been brought to you by the Marfan Foundation and its divisions, the Loeys-Dietz Syndrome Foundation, and the VEDS movement, and our partners in Europe at Versern. We thank you for making this such a historic event. It is by far our largest event ever, with nearly 2,800 registrants from more than 72 countries. We hope you've had an opportunity throughout this time and in the remaining days, even after the summit is closed, to connect with others around the world who share your condition, share your situation, or even just share some other interests in life. There's been so much great stuff happening in the community forums. The app will remain open for a while. We're not exactly sure how long yet after the summit has ended. So please continue to use that to make connections, because as you know, it is so much, everything's much nicer when you know other people who are on the same journey. We want to share a heartfelt thanks to our presenting sponsors, Brigham and Women's Hospital and American Communication Construction. Before we start, I want to make sure to mention that the International E3 Summit is a forum to provide an open discussion of issues related to genetic, aortic, and vascular conditions. Opinions stated in each of these talks are those of the speakers and not necessarily those of the Marfan Foundation or Versern. If you hear differences of opinion from speakers and want further clarification, please contact our help center at marfan.org/E3ask. And we do ask for your patience, as the volume of questions right now is very high, which is exciting, and we are so glad to have them, because that's why we're here, is to make sure people get the information they need when they need it from the experts who can give the best possible answers. But as you can imagine, there have been quite a few questions, and we want to make sure we get the right answers, and so it's taking a little bit of time. Today, we are fortunate to have Dr. Adam Bitterman present on Walking on Clouds, Foot and Ankle Pain Relief Strategies. Dr. Bitterman, would you like to come up and say hello, or are you want to hang loose until we're done?
I am here and ready to go. Nice to see everyone virtually. Good evening, good morning. Welcome to everyone around the world.
All right, so what we will have now is we have Dr. Bitterman's presentation, and then after that, we will go into Q&A. There are several questions already loaded into the session, but if you have additional questions that are not asked already, go ahead and drop them in under the Q&A. If you put them in the chat, we may not see them, so please make sure you put them in Q&A, and we'll get to as many of them as we can and see how far we can get through the list. We do want your questions answered though, so keep in mind, if we don't get to them tonight, you can always use the marfan.org/E3ask. And with that, I believe we will get ourselves started here. If I can get the screen to advance, what's happening? There we go. Oh, I'm so sorry. I forgot one last thing. Before you exit this session, there should be a button below the screen where you're viewing that says rate. And we are very much grateful for your feedback on every session you attend, whether you're watching live or at a later time. This is so, so helpful in us determining what topics and how to present different topics so that we are answering the questions and getting the information to you in the best possible way. So please do it takes less than a minute to rate this session after you have completed viewing for the time being. So with that, we will get started. Okay, let me make sure I turn myself off.
Welcome, everyone. This presentation is entitled Walking on Clouds, Foot and Ankle Pain Relief Strategies. The topics today will involve not only the feet, but the ankles, and also highlighting some areas involving quality of life. Now, the question is, why is this so important? Patients with connective tissue disorders, whether it be Marfan syndrome, Loeys-Dietz syndrome, Ehlers-Danlos syndrome, are living longer than ever before. With the medical advances that have been made and continue to be made, we are fortunate enough to live longer lives, more productive lives, and better quality of lives. However, over time, things break down. And it's very important that we understand the musculoskeletal etiology of pain in order to improve one's quality of life. So what's the big deal? Why is the feet and the ankle so important? Well, we frequently take this area for granted. This area is like a high-trafficked highway with many lanes going in multiple directions. You have nerves, blood vessels, tendons, ligaments, and bones all within a small area. The foot, in fact, has roughly 26 bones in total. Some feet may have slightly more due to accessory bones, but there are many active areas, and as a result, the fancier things get, the more things that can go wrong. Stay calm. We're going to go over some important topics today. So the foot and the ankle tends to look like the foot on the right side of the screen in a patient with connective tissue disorder. This happens to be a very flat foot, one without much of an arch. In fact, it's also a foot that has elongated toes, elongated bony prominences, and also one that tends to tilt out towards the side. This foot also tends to change sizes frequently, and it's not necessarily that the foot is getting longer, but more so that the bony structure is becoming more abnormal, and as a result, the shoe no longer fits. The shoe that you had a year ago doesn't fit anymore, and now you require a shoe that is much wider and also much longer. The medical term for a flattened foot, or one that does not have a very high arch or a normal arch, is called pes planus. When this flattened foot is combined with a heel that goes out to the side, we combine the terms and call them a pes plano-valgus foot. This is commonly referred to in patients with connective tissue disorders. When discussing the initial pain control with regards to foot and ankle deformities, one area that's frequently overlooked is the proper shoe. As I mentioned before, shoes need to be appropriately sized. And that may sound counterintuitive, but it's true. Frequently, roughly 75% of shoes that are worn with the incorrect size. So a few shoe pearls mentioned on this slide. Be sure to wear limited or low heels. Roughly a half-inch or even 1 inch is okay, but you don't want to be in the habit of having a flattened arch or a poorly structured foot and wear a high heel. You want to wear a heel, or rather a shoe, with appropriately cushioned soles. You want a stiff sole, one that has appropriate support, such that the forces are not going directly through the shoe onto the bony structure of your foot, but some of the forces getting dissipated by a stiff shoe. A broad toe box is appropriate because as the foot changes its shape, the foot can become wider in the front by the area of the toes. Having a broad toe box enables appropriate room so that all of the toes fit. A first web space sponge or a wedge rather, can be appropriate in order to prevent a bunion or limit the advancement of the tilt of the big toe. Then we can talk about custom molded orthotics or off-the-shelf orthotics, which play a role in controlling one's pronation and one's hind foot. The lower pictures demonstrate a picture or a graphic of an orthotic on a normal foot. The right-hand lower picture demonstrates one's left foot and right foot with and without an orthotic. The left foot does not have an orthotic, and you can see that the hind foot is tilting into valgus or going outwardly, while the right leg demonstrates a foot and ankle with an orthotic in place and a neutral alignment, as seen by the parallel lines. When trying on a shoe, it's important to understand that you want to make sure that the foot is appropriately sized and that you give the shoe a chance to loosen up. The time of day that you have the shoe tested also plays a role. If you go in the morning, your foot may not be as swollen as if you go later on in the day. Before committing to a purchase, be sure to have an appropriate time frame, walking around, trying different directions, trying different activities within reason, of course, before purchasing the shoe. With regards to the foot and the ankle in the setting of connective tissue disorders, there isn't much research. Unfortunately, reconstruction versus fusion of these foot deformities, there's not a lot of published literature that gives us many answers. What we know is that connective tissue is not normal tissue. When we try to reconstruct abnormal tissue to abnormal tissue, that's when we get into failures. The appropriate management most of the time involves bony fusion, as you can see below. What a bony fusion is, also known as an arthrodesis, is involving taking two bones, essentially gluing them together with hardware like two screws, and eliminating the joint. By eliminating the joint, you eliminate any micromotion or micromobility that can lead to instability and additional pain. In the setting of doing reconstruction, it's important to understand that you can't take your own tissue and reconstruct it. So frequently you need cadaver augmentation, called allograft augmentation, in order to appropriately reconstruct a joint that is abnormal. With regards to the ankle, it's not uncommon to frequently encounter loose ankles, ankles that give way or that are inherently unstable. These ankles result in torn tendons or torn ligaments rather, redundant ligaments that are no longer holding the appropriate stability. This leads to a sensation of the ankle giving out and ultimately requiring surgical treatment. Now, before we rush to any kind of surgical treatment, I tend to always try conservative measures, which would include physical therapy and bracing. But unfortunately, that doesn't always work. On the bottom left-hand picture, you see a schematic of a routine repair with various types of anchors and suture devices. Now, what I will tell you is this is not the best way to proceed in someone with a connective tissue disorder, as mentioned before. Therefore, in my hands, I tend to resort to the image on the right, which is using a cadaver tendon in order to reconstruct the ligaments. These are held in place with anchors, and they go into the anatomic footprints of the normal ligament structures. Again, the routine ligament reconstruction on the lower left, and a connective tissue disorder ligament allograft reconstruction on the lower right. Let's now dive into quality of life. There's a big overlap, and certainly what we need to understand is that patients with connective tissue disorders have changes in their endurance. It's no longer similar to someone of the same age. Their strength is different as their body type has changed. They frequently become fatigued. These patients have pain, sometimes out of proportion. There are GI abnormalities which can play a role in one's quality of life, as well as their oral health, athletic restrictions, cosmetic concerns, psychiatric and mental health well-being, which is extremely important, and then obviously pregnancy. Some of these are outside of the scope of this talk, but in order to be thorough, it's important that they're mentioned. With regards to pain, no one theory appears to be correct. With multiple theories, that just goes to show you that we don't have a perfect grasp on the true cause of pain in someone with connective tissue disorder. Frequent theories that are mentioned in the literature and amongst my colleagues include scoliosis, abnormal curvature to one's back, chemical abnormalities as seen here with TGF-beta and cytokines, which are fancy chemicals within the body that play a role in inflammation and likely pain. Furthermore, dural ectasia is a spinal abnormality involving the sac, which encases the spinal cord, but this is lower down in the lumbar spine region. And then degenerative arthritis that can result from wear and tear or additional deformity. And this can be not only in the foot or the ankle, but the knees, the hip, the back, the shoulders, the wrist, and the elbows. Anywhere where there is a joint, you can have degenerative change. Keeping with the scope of the ankle and the foot, these are obviously high trafficked areas, as mentioned before, roughly 10,000 steps per day. It's no wonder that these break down. In fact, it's quite shocking that these take this long to break down with the amount of trauma that they sustain. With regards to quality of life, one study that came out in 2016 by my colleague, Dr. Sponseller, and his team in Baltimore, they evaluated 230 patients. And they noticed that their top concern amongst these patients involved cardiac, which makes sense, back pain, and fatigue. So once we eliminate cardiac issues, which obviously is paramount, orthopedic, back pain, and then fatigue, or one's ability to participate in things, played a major role. And these clinical manifestations are not similar amongst different individuals. In fact, they're different. And no two symptoms are the same. Unfortunately, in the United States, the quality of life is less, and it's less so than in the United States norms. Those experiencing the most severe pain in the connective tissue realm included patients within a 25 to 45 age gap. With regards to fatigue, again, incorporating orthopedics, there's a limitation in one's social interaction. So the ability to interact with others is limited and plays a role. There's lack of function in the workplace, and if you can't work, there's no financial income, and that can play a role. The feeling of depression and anxiety overall, the inability to cope with daily activities or to participate in one's daily activities, ultimately potentially compromising one's hygiene and overall well-being. And then modifying someone's daily activities can be detrimental to someone's mental health. Important to keep that in mind. Ultimately, the connection to someone's foot and the ankle is if there's deformity or you can't function appropriately, again, those frequently are taken for granted, can certainly impact one's quality of life. Athletic participation, I'm not going to get into too much detail because there are folks with much greater intelligence than mine that will give you appropriate direction. But certainly in the youth, their ability to interact with others is something not to be taken for granted because it does help with not only their mental health, their mental well-being, but also their physical health. I would advise everyone to approach this topic with caution. What your friend can do or cannot do should not necessarily be a directive for yourself. Everyone is different. No one size fits all, and everybody has to have an individual approach. As far as heart rate, it's important to know that every activity can adjust the heart rate differently. Heart rate is key, but systolic blood pressure also plays a role. You want to avoid the activities that lead to one bearing down or pushing or holding one's breath. That'll increase your blood pressure, thus increasing the pressure on your aorta. You want to adjust. You want to find what works best for you, as there is no general consensus. Again, I will yield to the cardiology team members on the panel to give you further input. Finally, again, I spoke briefly on the foot and the ankle and also quality of life. I tried to merge the two, and I'm happy to discuss further on foot and ankle issues. But we all must be on the lookout. Marfan syndrome symptoms can be addressed not only from an orthopedic standpoint, but a cardiologist may be seeing these issues. They can refer them to the orthopedic surgeon, and an orthopedic surgeon can also diagnose these diagnoses and get them to the correct people. Marfan syndrome and foot and ankle issues affect people of all different shapes and sizes. And if they don't go treated appropriately, they can lead to catastrophic consequences and severe immobility and lack of function. You need a multidisciplinary approach. It's not all handled by orthopedists. It can also be handled by pain management and also alternative measures like acupuncture and alternative medicine. Early recognition is key, which leads to early treatment. Understand the importance of this because an improvement to our medical advances today leads to longer lifespan and better quality of life overall as these musculoskeletal injuries become more prevalent due to mechanical breakdown. Again, I spoke rather briefly, providing everyone with a lot of information, and I'd be happy to answer any and all questions. Again, here's my contact information, and I look forward to answering questions in the chat. Thank you.
Okay, so we are now going to take some of the questions that were placed inside the Q&A. Some of them have been upvoted by many folks, and so we'll start with those and get through as many as we can tonight. And we'll start then with this first one that has 14 people who have agreed they would like an answer to this question. It says, I see my feet changing as I age, bunion with worsening big toe bending outward, and I want to maintain my mobility and active lifestyle for as long as I can. How do I prevent future foot problems? When and what kind of foot surgery can help Marfan feet? Are there any non-surgical interventions that are recommended?
So very loaded question, but one that sort of needs to be teased apart. Number one, as we age, whether you have connective tissue disorders or not, your foot will change size. And the reason it may change size is manyfold. Number one, you could have tendon failure, which leads to the foot becoming elongated and also sort of swerving outwardly. Additionally, the shoes that you wear can affect the shape of your foot and also the size of your foot. You want to make sure, again, as I mentioned earlier, that you're wearing a shoe with a wide enough toe box. That toe box alleviates pressure. When you have pressure on the inside part of your foot, you are going to tilt your big toe, and your big toe will certainly bully the lesser toes, leading to what we call a bunion. Now, if you have connective tissue disorders, you're already behind the eight ball to some extent because your tendon failure may be exacerbated by the types of shoes you're wearing and the lack of support. So it's very common, and I see it all the time in patients of all ages, whether they be in their 40s all the way up to their 80s or 90s, that constantly say every year or so they're having to remeasure their foot. They're having to adjust their foot and get new shoes. So that's very common. As far as surgery is concerned, again, difficult to answer without a full, thorough exam. Nonetheless, it's important to know, in my practice, conservative treatment is key. You don't want to rush into a surgical treatment, especially if there's a connective tissue disorder that's underlying, because it's a bridge that gets burned. And by burning a bridge in connective tissue disorder, especially around the ankle and the foot, it can lead to much more difficult revision surgeries down the line if things are not done appropriately. And again, that's part of the reason why I mentioned fusion. Now, the fusion surgery is not for all, and the fusion surgery can play a role in a bunion. So I imagine there will be more questions sort of diving deeper into this topic, but just as a brief overview to start, that would be my first spiel, so to speak.
Very good. I'm sure there are more questions sort of related to that as we move through here. Next question. Both my husband and daughter, looks like these are LDS, Loeys-Dietz. My husband and daughter have pain in the back of their heels. My husband has an appointment to get it looked at soon. What types of heel and ankle pain are common with LDS patients?
So it's a heel pain in general, LDS, Marfan's, EDS. There's basically a list of about 20 different diagnoses. And the most commonly diagnosed issue in that region in the back of the heel by the bony prominence is what's called Achilles tendinosis. Some people refer to it as a pump bump, and it's essentially a big, large hump on the back of the calcaneus where the Achilles tendon inserts. And it can be a result of a very tight musculature complex in the back of the calf, which leads into the Achilles tendon, thus attaching to the calcaneus. The key is stretch, 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 and stretch some more. And if you think you've stretched enough, stretch some more. And that's also where a physical therapy regimen is critical. Things that you can do, you can purchase some gel cups off the shelf at certain pharmacies. It's just the heel. It's literally about a cup yay big within my fingers, as you can see. And it's for the heel, and it lifts the heel off the foot, off the floor rather, or the sole of the shoe slightly, to take the tension off of the Achilles tendon.
Literally the Achilles heel, huh?
The Achilles heel.
Okay, next question. I'm 63 and have Marfan. I have very high arched feet and a midfoot bone, maybe the navicular, not sure, that is becoming painfully overgrown. It rubs against any shoes that sort of fit my long, super skinny, hammer-toed, unstable feet. I also develop stress in my metatarsals very easily. Stress fractures in my metatarsals very easily. Any advice for high arched Marfan feet, any treatment for the painful bone on top?
So another hot topic. High arched feet, also known as pes cavus, can happen in patients with Marfan syndrome. Notoriously, historically, whatever you want to call it, Marfan feet tend to be flatter, elongated, long toes, long digits, similar to what we find in the hands. Now, when someone has a higher arch, it's kind of like a stool. If one of the legs of a three-legged stool is off, the chair, the stool will tilt. The same thing can happen with the foot. Rule number one, you want to try and normalize the arch as best as possible. And you can do that with a neutral shoe. You can do that with an orthotic or an insert that doesn't support the arch, but actually does the opposite, sort of allows the arch to fall back into what we would consider neutral. Now, again, there's a lot of stuff that goes into it. If you have advanced arthritis, your arch may not fall down, your arch may not be flexible. If it is, there are proprietary inserts. One name is called an arch rival, which is a brand. I have no affiliation with it, but it is a brand orthotic that you can get online through your store of choice. And basically it's a means of letting a higher arch sort of fall down back into a neutral alignment, thus giving you alleviation of the pressure. Again, I'm sorry, Angela, I'm trying to keep these brief so we can get to as many as possible. For those that are listening, if you have additional follow-up questions, you can feel free to email or tweet or whatever.
That's very gracious of you, and I appreciate you, your consideration of the long list of questions we have going. Okay, next one. My favorite podiatrist, who retired a few years ago, told me that my Marfan feet needed a soft, custom-made orthotic to provide maximum cushioning. I got them and loved them. An earlier E3 speaker suggested that CTD patients needed hard orthotics for greater stability. What's your opinion?
Great question, great point. And this is where it kind of comes into the individuality, if you will, of the patient, of the individual. Certain other conditions can cause problems with the foot outside of connective tissue disorders. Additionally, patients with connective tissue disorders can get the same pathology. And this just reminds me, I didn't address the navicular from the previous question. So have them feel free to email and go into it more. Nonetheless, the patient with the connective tissue disorder can have the same conditions that people without connective tissue disorders can have. My point is yes, in certain circumstances, diabetes, a soft cushioned insert is appropriate. In a flexible connective tissue disorder person, a more solid or a stiffer orthotic may be most appropriate to prevent a lot of play. As you can imagine, the more cushioning that exists, the softer it is on the soft tissues, the softer it is on the bony prominences, thus the more play you can have. The cushioning does not live forever, and as pressure is put on that cushioning, it can get smushed, for lack of a better term, and as that happens, you get more play, thus the orthotic becomes non-functional.
Great question. Next one, do you recommend wearing shoes in the house during the day for support? I find my feet are aching just from standing. Any advice on how to achieve day-to-day relief would be great.
So the short answer is yes. I rarely encourage barefoot walking for patients with connective tissue disorder that I see. Even if it is a slipper, certain brands of slippers, again, not really getting into brands, but I know people want to hear the brands. And for full transparency, I have no financial relationship, but Uggs makes a nice slipper. Certainly they are more expensive than most, but what I like about them is their solid rubber bottom, that black bottom that they all have, gives you appropriate support. And that's what you need, because when you're not wearing appropriate shoes, all of the forces are going directly through to the bones, and that's where you get stress fractures and other major issues. So a sneaker is paramount, a shoe is the next level, and then a slipper would be ideal in the house.
I have those Ugg slippers. They are wonderful. Do you have tips on sports or dancing shoes for Marfan flat feet? I find it very hard to find shoes that support my weak ankles, are big enough, she says European size 42 for women, and offer enough support that the balls of my feet don't immediately start to hurt. Tips on soles.
So again, what you want to do is you want to try the shoe on and walk around basically as long as they'll let you before you get either thrown out of the store or arrested, etc. Try the shoe on, let the shoe sort of relax on your feet and see how you do. With regards to the soles, there are, regards to the ball of your foot, certainly you can have additional pressure if you have a flattened foot as a result of compensatory changes. I'll sort of spare you the dynamic or the biomechanics of the foot, but when it is a flatter arch, the front of your foot tends to rotate in the opposite direction so you can accommodate the floor. When that happens, you can get extra pressure on the foot, thus resulting in a pressure point to the ball of your foot. And there are pads or parts of the orthotic that can be customized for you, thus alleviating the pressure in that area.
Here's another one about flat feet. What kind of pain can result from Marfan flat feet, weak ankles, hammer toes, all the weight on the balls of the feet? Any recommendations on stretching exercises? Can pain in the hip result from this?
Yes, so pain going up the chain, because obviously everything is connected. The foot bone is connected to the heel bone is connected to the leg bone, etc. My point is, when you have the flattened foot, that ends up giving you a tight heel cord. A tight heel cord is the band of tissue in the back of the ankle, also known as the Achilles tendon. And when that's tight, that can just sort of drive this cascade of deformity and to spiral out of control. So yes, you want to stretch. And as you continue to develop the flat foot deformity, your tendons, which are your connective tissues, are already quote unquote disordered. Thus that leaves worsening deformity and continued pain. So getting a brace, getting appropriate orthotics that alleviate this disorder is key.
Do you have recommendations on which stretches, or, not that you need to demonstrate, but like, or
Yeah.
even just certain types of stretches that we could Google and drop in like a YouTube link?
So certainly calf stretches in general are what you want to focus on. And essentially imagine leaning against a wall and then putting one leg forward and bending that knee as you're kind of lunging into the wall. That'll stretch the opposite leg that's not bent. You keep that heel down. Otherwise, what you can do is if you have access to a stairwell and appropriate railings, you want to stand upright, okay? So if this is the stair, you want to put the ball of your foot on the stair, holding onto the railing, of course, and then let your heel go down. Now imagine if I'm standing, it would be like this, and this part would all get stretched. It's hard to really demonstrate it, but I can try and find some information on that and send it out.
I think that's helpful. Thank you.
Mm-hmm.
Next question. AFOs, strapping, PT, all of it, none of it. I have heard it all. I have neuropathy in both feet, turned in knees, and beyond flat feet. I've been in custom-made orthotics for years, along with PT every week with a focus on straightening and proprioception.
Yep.
Sorry,
Very good.
I butchered that. But
No, you got it.
still rolling and falling. Any doctors near Vermont seeing hypermobility patients?
So my blanket statement is there are many, many fantastic orthopedic surgeons and podiatrists across the world. A condition like Marfan syndrome may not be as known by most, and if there's continued problems, you may want to seek out an academic medical establishment or an academic medical center. That's number one. Number two is I'm always happy to try and give recommendations or names of people that I know who may or may not be familiar. AFO is a custom brace. It's an ankle foot orthoses for those that are not aware. It's a custom brace, and it's basically a plastic shell that goes around the back. There are various types. There are many variations to this. But ultimately, it is a custom brace, and it is a means of preventing surgery. So what it sounds like for this individual is that they have advanced flattening to their arches and advanced arthritis in the ankle and the foot, thus giving problems going up the leg. And I think if you're not comfortable, if that's where this question is going, certainly seeking out an opinion at the University of Vermont or Dartmouth, I'm not sure where you are, but they may be able to give you better advice.
Thank you. This one is about repeatedly getting breaks in small foot bones just from stepping. I have arthritis, cap boots to treat, have garden variety orthotics and athletic shoes. Any ideas?
So certainly I would check your vitamin D level for that person that's hopefully they're watching. Because if you have a low vitamin D or you have osteoporosis or even osteopenia, those are situations that can lead to chronic fractures or chronic breaks. The next thing that you want to worry about is if you have all of that being normal, what it sounds like is you're putting excessive pressure on certain areas of your foot, and the foot is not really getting a chance to heal. If it's constantly getting sort of badgered, even a low impact force can lead to chronic stress within the foot. So having someone evaluate your overall alignment, it may just be something as simple as offloading a pressure point, giving you relief.
Okay, let's see, next one. My daughter was born with severe talipes, and because she is so hypermobile, even after several surgeries, her feet are very unstable. We cannot have anything else done now until she is fully grown, and she's 9 now. How common is this amongst SMAD3 children? Any idea of what the future may hold for her?
So this is a classic case of a deformed foot, potentially from birth, potentially from the condition. And certainly it's genetic. And as the question submitter mentioned, nothing further can be done. And that's a little bit concerning in the sense that maybe the deformity is so severe that it may require bone work. And I would yield to my pediatric orthopedic colleagues because you certainly want to be cautious when breaking bones or doing bony work in someone who's less than what we call skeletal maturity. Skeletal maturity is once an individual in females, it's roughly 14. In boys, it's roughly 16 when their bones are done growing, at which point you can then break a bone, realign a bone, reshape a bone, and get it to heal. Prior to doing so, you put the growth plate at risk, which can lead to abnormal growth or lack thereof, or stunted growth in a particular area if it violates the growth plate. What I would recommend at this point is bracing or orthotics to try and get this individual to function at their highest level, and then certainly if and when they are ready for a surgery and one is amenable and it's appropriate, then I would move forward. But tackling this now, ideally with bracing, can hopefully alleviate the issues down the line and make them as productive as possible.
Always hard when when the bones aren't quite grown yet.
Yeah.
Okay, this one, I have a bunion and hammer toe on one foot. The hammer toe lays on top of my big toe, and wearing leather shoes is extremely painful. I have Marfan. If I choose surgery, what should the surgeon be aware of with my Marfan foot?
So that's a condition called a crossover toe, where the second toe is getting bullied by the first, but then just decides to hop over it. And that's usually a two-part phenomenon. Number one is the connective tissue loosening, so to speak, leading to partial deformity with the bunion, and then the second toe going in the opposite direction. So it kind of creates a crisscross. All that I would recommend that your orthopedist or your podiatrist is aware of is that you have the connective tissue disorder, that he or she knows about it, and make sure that they propose an appropriate surgical plan. Now, the surgical plan is hard to judge through this type of venue. Obviously, it depends on the deformity, because certain procedures within the bunion pool of procedures are appropriate and some are not. Don't be alarmed if you hear the word fusion thrown around for your bunion, because that allows the bones to heal solidly. If you're relying on soft tissue correction, then certainly that connective tissue can fail. Because as I mentioned, when you take abnormal connective tissue and repair it to abnormal connective tissue, you're not going to create normal tissue. You're creating just more abnormal tissue which can unfortunately fail. And it can lead to a recurrence of the bunion.
Next question, can you tell us more about peripheral neuropathy, the causes and treatment?
So peripheral neuropathy is abnormality to the nerves, okay? It's frequently associated with diabetes. Now, I'm not saying that you have diabetes. There are neuropathy conditions outside of that, but certainly you want to make sure that you don't have that. Number two, it is basically it's a loss of sensation. It's an abnormal sensation, and it can be a painful condition as well. And depending on the specific type of neuropathy, it can begin in the toes and then work its way north, affecting the knees, and then can also affect the fingertips and work its way up. What I would recommend is seeking the expertise of a neurologist.
Very good. This one is switching gears just a little bit. My son has Marfan syndrome. He's 3 years old. He sits in a W position and cannot sit crisscross style. Our doctor says his femurs and tibias are rotated inward, but that we should wait. Should we be doing something?
So the W position is I don't want to speak on behalf of my pediatric team members, but certainly the W position is a little bit of a dreaded position. Every child does it. And I always encourage my own children to not sit like that, for what it's worth. But it can yield to inward rotation of the femur, thus causing just overall rotational deformities to the lower extremities. And again, seeking out the expertise of a pediatric orthopedic surgeon, of which I am not, but Dr. Sponseller is, I would yield to him for that type of question.
Dr. Sponseller has spoken or is still speaking during the summit too. I'm sure we can find the link to that. And
Usually tag team, where we've tag teamed in the past. I guess he's busy getting some honor right now. So
as he should be. Okay, next one. Peripheral venous insufficiency. Venous is causing this session has been giving me tongue twisters like none other I have done through E3. Okay, intermittent swelling and pain in right foot. Great. Saphenous vein closure procedure was recommended. Is that the best method to use on someone with Loeys-Dietz, or what would be appropriate options? Any other special considerations giving an LDS diagnosis?
This is more of a vascular specific question. Not that we're, there's obviously a lot of crossover. When we talk about connective tissue disorders, not only does it involve the tendons, the ligaments, and the joints, but our blood vessels, believe it or not, are a form of connective tissue. And as everything else can fail in Marfan's Loeys-Dietz, Ehlers-Danlos, these are affected as well. And if there is dysfunctional vascularity, that can lead to swelling or discoloration, etc. If the veins are not functioning, then the blood is not returning appropriately, or it can pool. As such, compression stockings are one option, and then following up with a vascular surgeon is key.
Everything is so connected, and
it sure is, and that's the other thing. We're learning more and more about what it means to have a connective tissue disorder outside of aorta, and certainly, don't get me wrong, that's the most important, but with the advances that we have, everything else is breaking down because we're living a lot longer, so it's key to know that.
So that leads well into this one, and I think you may have already addressed it a little bit, but I'm going to ask, I have virtually no padding left on the bottoms of my feet. I'm in my 60s now. I cannot stand barefoot unless I'm on a thick carpet. Is there anything you can recommend short of wearing shoes with good padding?
Shoes with good padding, number one. Number two, I get asked a lot if we can inject fat, and people certainly volunteer other areas of their body to take and inject to their feet. I am not suggesting that. That is not something that I would recommend. I know that there's artificial fillers that are being injected. I would advise buyer beware, approach with caution. I have not done that. The short answer is find a shoe, find a sock, find a surface that's most comfortable for you. If you're standing washing the dishes, get one of those pads. If you work as a clerk somewhere, make sure that the store provides you with one of those appropriate pads that you've seen, and that can make a world of a difference.
So speaking of injecting fat, this one says, I had a bad knee 15 years ago and was injected with rooster guts. It worked wonders on my knees, still no problem. Can this be used on my ankles? The doctor moved and yet to find another doctor who knows the correct name of it, but it was a miracle injection. Any ideas?
So this is not rooster gut. It's usually rooster comb. It's what's called hyaluronic acid. It's also known as viscose supplementation. It's also known as gel injections. And it is indicated for arthritis, usually in the knee. And it can come in as a series of 1 injection all the way up to 5 injections, 1 per week. Can it be done in the ankle? Yes, it can. Is it covered by insurance? Usually not, because it's considered off-label, meaning the FDA has not approved these medications to be injected into the ankle. Full transparency, I have injected gel injections into the ankle. I think it required an out-of-pocket payment by the patient. Don't quote me on that, but Yes, it can be done. Yes, it works wonders, but it sounds like you have arthritis in the knee and possibly the ankle as well.
Well, I'm certainly glad we could clarify the rooster gut question and the actual, I think that was as much the question as anything else. I've been looking for someone to help and didn't know what to ask for. Next question. Our son is 3 with Marfan. His left ankle leans inward, his toes are cramped, and the big finger goes below the other ones. Can something be done to correct any of this, and will this lead to pain?
How old did you say he was? 3?
3.
So sometimes foot deformities can result from what we call packaging disorders. What do I mean by that? It could be Marfan related. It could also be how the baby was inside of the mother's womb. Meaning if they're curled up in such a fashion inside of the womb and they come out, you can have particularly club foot. That's another example. In this, it sounds like it's the opposite, where it's flatter and then you're getting changing to the alignment of the toes. At this stage, what I would try and do is the stretching. How do you stretch a 3-year-old? Well, essentially, you want to take the foot, and instead of leaning against the wall, you're pushing the foot up to try and loosen up that heel cord. Outside of that, you want to make sure the shoes that they're wearing is accommodating and not too constricting to the front toes. And then once they reach skeletal maturity, then certainly it's worth an additional discussion.
All right. I feel like having had small children, about everything you try to do with your child is somehow stretching them. So hopefully they're always.
The thing is, Angela, with children, they can remodel. And what do I mean by that? Is their bones can remodel and reshape. So you don't want to rush to a surgery this early, in my opinion. Again, that's a very superficial judgment based on what you're telling me in the question. So I wouldn't rush to any kind of surgery. Obviously, you may want to try a toe spacer in between, which is basically just an off-the-shelf like toe wedge that can bring the big toe over and try and alleviate some of that deformity.
It's really good to know. Okay. Is there anything that can be done for Taylor's bunions other than donut cushions? They rub constantly, but my extremely flat, long, narrow feet require tight lacing for support.
So Taylor's bunion, for those inquiring, is a bunion on the outside of the foot. A regular bunion is the big toe. A Taylor's bunion is the 5th toe. Yes, outside of conservative treatment, you can break the 5th metatarsal and realign it and give you significant relief. It's a very successful procedure. You can do it minimally invasive now, so there isn't a big incision and recovery is a lot easier. And having connective tissue disorder when you're doing a procedure like this, while it's always worth mentioning, may not, should not play much of a role in your overall recovery. But please don't quote me on that.
This person asks, can you speak more about some effective alternative therapies for foot and ankle pain?
So a lot of it is inflammation. And the key with regards to anti-inflammation is exactly that. You want to lower or put out the fire. And that can be done many ways. There are prescriptions, there are over-the-counters, and there are alternatives. The main over-the-counter is a group called NSAIDs: Motrin, Advil, ibuprofen, Aleve, medicines like that. The prescription version anti-inflammatory is Celebrex, meloxicam, steroids, medicines like that. Then there are also topical anti-inflammatories or over-the-counter numbing agents or nerve modulating agents, and that can be Voltaren gel, Biofreeze, Aspercreme, Bengay, those types of medicines. And then there's the alternative medication realm, which includes spices, turmeric, and CBD. CBD is an anti-inflammatory that has great success in various areas. We're actually exploring it as a study in a certain area of the foot, but nonetheless, we're learning more and more about CBD. Turmeric, I've had great success with patients looking for a more alternative or holistic approach. And then there are various what are called anti-inflammatory diets, which I will be truthful in saying I don't have much science behind them, but I have patients with inflammatory bowel disorders, Crohn's disease, things like that, that do not want to ingest a lot of inflammatory inducing agents. And so they use a lot of turmeric, they use a lot of greens, they use a lot of Indian spices per se, and that has yielded great results. But again, no science to back it.
Got it. Just as a note, there is a session tomorrow at 7:30 p.m. Eastern on CBD and pain, if you're interested in exploring that more. Next question. I had my right ankle fused 13 years ago and have managed this procedure well. My left ankle now requires surgical intervention. Is ankle replacement viable for a Marfan patient? I'm 7 foot 2 inches tall and I can't imagine coping with activities of daily life with 2 fused ankles.
Great question, and I'm glad that that was brought up. You know, an ankle fusion is the workhorse for ankle arthritis. And basically you're taking the 2 bones that are arthritic and you're gluing them together. The newer, for lack of a better term, sexier, more attractive orthopedic option is the replacement. We hear it frequently with regards to knee arthritis, hip arthritis, shoulder arthritis, and the replacement is the new wave. And there's great technology for this. What I will tell this individual and everyone else that's listening is the ankle replacement is not like the knee or the hip. The hip and knee replacements are the workhorses for arthroplasty or joint replacement, meaning their track record is a lot longer. It's been out there for a lot longer, and it can last for up to 30 years, if not longer. The ankle, unfortunately, is not that good. It's a great replacement, but it's not as good in terms of lasting as long as the hip and knee. So I generally say it can last roughly 10 to 15 years. So depending on how old this individual is, if they are 50, they should plan on that implant failing and possibly needing a revision. Long story short is certainly 2 fused ankles will make it very difficult to walk. You may have a limp if you don't already have one, and it may make it difficult to accommodate uneven ground. You'll certainly be able to drive, you'll certainly be able to function, but if you can get an arthroplasty, I would try and do that to maintain your motion.
Okay, I think we have time for just a couple more. So I'm scanning down here to see if I can find ones I can sort of combine. But the next question here is, I have what appears to be small knobs of tangled fascia on the bottoms of both feet, causing pain in ankles and tight toes. The tissue has become smaller and more fibrous, i.e. can be moved a bit with regular massage, but it won't go away. What causes this and how to get rid of it?
So it's a nodule. Where did you say it was?
Oh, my screen just skipped. Small knobs of tangled fascia on the bottoms of both feet, causing pain in ankles and tight toes.
This sounds like what's called plantar fibromatosis. Essentially, they are little nodules, little areas of inflamed plantar fascia, and it can be associated with other disorders. And I'm not going to necessarily mention them because I don't want everybody's head to start spinning, but it may or may not be related to Marfan syndrome. As I said, patients with connective tissue disorder, whatever that may be, can still have conditions that those without it have. You can have multiple disorders outside of your connective tissue disorder. But it sounds like plantar fibromatosis, which are little nodules, and they're in multiple areas. You can also have them in your hands. And the treatment is purely conservative. If you do need to get aggressive, surgical management involves a wide excision and has a significant morbidity. So I would try and encourage conservative treatment as much as possible, and that's with orthotics and inserts and offloading those pressure zones.
Okay, when wearing rigid AFOs, this is about a 6-year-old, is the footwear important or is it the AFOs that offer the support and positioning? I know we see this question fairly often because they can be hard to match up, footwear and the AFOs.
Yep. So the footwear you want to keep neutral. The AFO, which goes into the foot, has the padding on it, which can then help modify the foot and the ankle. So the shoe wear should be neutral and should fit the plastic or whatever material the AFO is made out of. You want to make sure it's wide enough so that it's not compressing the AFO onto the patient's foot, but sturdy shoe, and then build up from within.
A brand that I know we've recommended, and I know some parents, some Marfan parents who have used with children that works really well, is Play, P-L-A-E. I don't know if you've seen those, Dr. Bitterman, but they are, some of them designed specifically with exactly what you said in mind. Very neutral, and they work wider so that they can fit the AFOs in.
Mm-hmm.
There's a question in here about the brand of the recommended slipper. I believe that was Uggs.
Yeah, again, Uggs is just what I know. I have a pair. My wife has a pair, but they just tend to have a thicker sole on the bottom, which I think gives appropriate support, and they have cushion within it as well.
Okay, what do you recommend to best keep the fibula in place? Is there any way to get mobility in a great toe after the fibula has been subluxed for years?
Do they, I'm wondering if they mean the fibular sesamoid or if they mean the fibular bone. Difficult question to answer, but the fibula can certainly subluxate if it's a connective tissue situation. How it relates to the big toe, I'm not so sure, but I would encourage that person to reach out to me, social media, Twitter, or email.
Okay. I've got one more here, and then I think we're going to wrap up because I think many of these have been answered in some way. If your question, again, if it is not answered through this conversation, please do submit it to marfan.org/E3ask, or you can contact Dr. Bitterman directly since he has put his information out there for you. But we'll do this last one, and then I have a few other pieces of information to share before we wrap up for tonight. This one says, I'm knock-kneed and have severe hip pain. The pain radiates all down my leg from the hip. Is there anything in regard to exercising that might alleviate the pain through stretching?
Yeah, so stretching from the pelvis down, the quadriceps muscles, the hamstrings, meaning the front and back muscles respectively, the calf, and then core strengthening, having a good base around the abdomen, involving the abs, and the belly will help tremendously as far as just maintaining your overall posture. And then, pardon me, when you're upright, having strength to those calf muscles is key.
Okay, so as we wrap up, first of all, thank you so much for such, thoughtful and thorough answers to all these questions. I know there were a few more. Like I said, I tried to ask ones that didn't have some form of an answer already given, but if you have more or you want further clarification, contact Dr. Bitterman directly, or you can submit them at marfan.org/E3ask, and we will be working on getting those answered as quickly as we can. Please do complete the session survey as you exit viewing this session, whether you're on live or at another time. These surveys, the session surveys, are super brief, less than a minute to complete them, and they're very valuable to us in knowing what and how you would like information that's important to you in the future. We want to make sure you're getting the best possible education and information, and this really helps us do that. Second to that, you can do today or anytime through the weekend, I would recommend completing the summit survey. This is a whole summit survey, so this is not just about any specific session. It is now open. It will remain open for a while, but if you go to marfan.org/E3survey and complete that, we would be very appreciative of that. And to show our appreciation for that, we are going to draw 3 surveys that have been completed at random, and they will be awarded a $50 USD international debit card. So complete your full summit survey, and you could win some cash, essentially. We really very much appreciate it, and want to make sure that if we're able to do something like this again, want to make sure we have it all in mind as we expand and make it even better the next time. Also, if you have not yet visited the virtual exhibit hall, there are some great resources and folks in there that might be able to offer you additional support in your journey with Marfan or Loeys Dietz or whatever connective tissue condition you are working through. Also, along those same lines, as I mentioned earlier, you can connect with the community through the Marfan or through the discussion boards and the forums. There's a lot of great conversation happening there. If you haven't yet visited there and met some new friends or people with different types of interests that might be the same as yours, I definitely recommend it. And if you are sharing your experience with your community online, social media, we invite you to use the hashtag E3Summit20 to help further connect with both us and other participants in the E3 Summit. And finally, if this session and others that you have attended have been meaningful to you and you are able and feel moved to do so, we are inviting you to please help us make more programming like this possible through a donation at marfan.org/donate. A couple more things that are coming up, just because we know they are of interest to folks within our communities. Aortic Disease Awareness Week, which you may have heard in the past as Aortic Disease Awareness Day, is now expanded to a full week. This is a worldwide event that is powered by the Marfan Foundation with partners all over the world, and we hope you'll participate in our awareness project by raising your hands to raise awareness of the risk factors for aortic disease. You'll see here some examples of how we've done this in the past, and we invite you to do the same, share your condition on your hand, raise your hand, and then we use these. You can use yours on your own social media to spread awareness, and then we also use these to make videos and things to show all the different ways that people need to be aware of the risks of aortic disease. Information is available in the Summit app, on our website at marfan.org, and in our social media. With that, thank you so much to Dr. Bitterman. Thank you so much to all of our participants tonight and your wonderful questions. This has been a great discussion. I know that if you are interested in more information on this, we do have a few resources on our YouTube channel. If you go to YouTube and look for the Marfan Foundation, there are a few things there. There have been a few resources dropped into the chat, so you want to check through there before you sign out. Any final comments or remarks you'd like to make, Dr. Bitterman?
No, this was great. I hope I was able to touch base on most. Certainly I didn't get a chance to get through everything, but like I said, I welcome the interaction and the opportunity to clarify anything or to go into more detail if needed.
Well, this was really very good, and I'm sure has been helpful to many people, and will continue to be, as the recording of this session and all the other sessions from E3 will be within the app. This one should be up by tomorrow. If you want to come back and view again later, or you know, refer somebody else to it, or any of the other sessions, they go live, they go recorded live back into the same link where you viewed it, just as soon as we can get them back up, provided Zoom cooperates with us. So with that, we'll sign off for tonight. Looking forward to seeing everyone around E3 the next few days as we finish up. And thank you so much. Have a good evening.
Good night.
Bye.